Hi, I'm Tesha Monteith. I am co-chair of the IHS Membership Committee. I'm pleased to have Professor Peter Goadsby here to talk about the classification. He's chair of the Classification Committee. And why don't you tell us where you're affiliated?
Well, Tesha, hi. I'm Peter Goadsby. I'm chair of the Classification Committee, as you said, and I'm academically affiliated with the King Abdullah University of Science and Technology in Jeddah and at King's College in London.
And I also want you to, just before we dive into the classification, tell us about your journey as a member and leader in the International Headache Society.
Well, my mentor, Jim Lance, advised me to join the International Headache Society in the mid-1980s, I would say. And I started to go to meetings and eventually got involved. First thing I got involved with was the publication committee.
Okay.
And then after a couple of years doing that, I was tapped to become the editor of the journal, which I did for some years. And a little bit period after that, I was the first elected president of the International Headache Society, actually, which I'm quite proud of.
Wow. And then you also mentioned something about you got the journal online. I remember you mentioned that.
Yeah, I stewarded the journal from paper submission. Just imagine it. You used to print stuff out and send it to us. From that to entirely the way you see it today, which was online. It was quite a thing to get colleagues back in the day, to think that you didn't have to send us pieces of paper. And actually, for a while, we had to accept both paper and online submissions, and eventually got rid of it.
And so why don't you tell us a little bit, first of all, how long have you been the chair of the Classification Committee?
I've been the chair of the Classification Committee now for 5 years, 6
Okay.
years.
All right. So I want to talk about potential revisions, but I also want to talk about your big vision.
Well, the classification committee, for me, firstly, I don't want to fix something that's not broken. So the classification has served us very well. It's been important in research. I think it's used in clinical care. It's certainly been the vehicle, one of the primary tools that's been used for the development of new medicines. The triptans, particularly now the CGRPs, have all been done using the classification. So it's been, I think, wildly successful. It's been adopted by the words are adopted by the WHO. It's used by just about every country and regulatory people in the world. So my first vision is not to break it. I've been given a really precious resource, and I don't want to break it. That said, I think it's important to stand back 40 years later and ask some big picture questions. Have we got the categories right? Are there things in the appendix that should be in the main area? Are there things that have maybe ought to go back to the appendix? Are there new things that we need to do? And overall, I have a vision of it being a very much collaborative effort with the committee and with the membership at large. There's not a lot of knowledge in headache around the world, and it's not residing all exclusively in the committee, no matter how clever my committee members are.
Yeah. And so we had a wonderful workshop, and I think there was a lot of engagement. And so tell me about the process and collecting some feedback from our members that have this wonderful wealth of clinical knowledge and some research knowledge as well.
So members should be aware that the process we're using this time around is firstly to be careful about minuting our meetings of the committee and having them approved by the board, and then they go on the International Headache Society website. So if you're a member, you can read all the minutes of every meeting that we had. They're all there. And then we do a summary editorial for the beginning of the year for cephalalgia, so that folks can read about what we've been talking about in the last meeting and the kind of things we're doing. And the next part of the process is that when we come to, we're not going to wait for one big ICHD 4 beta. What we're doing as we go is, if we think something's important enough that it needs change and needs discussion from the headache community, we're going to be doing shorter papers that focus on something. So the first one's going to be about where the demarcation of secondary headache is. What do you call secondary? What do you call primary? How do you call the mixture? And we're working on a paper for that, which folks will see in cephalalgia probably in the next 3 to 4
And
months.
that's post-traumatic headache. We had that discussion.
Yes, exactly. And so we want to put out our thoughts as we go. So I don't want to get to the end of the process and then have a whole lot of people say, that's all crazy. Someone will say that at any rate. But we want to have the opportunity to let people see where we're going. And if someone thinks we're really going in the wrong direction, better to hear about it soon. And then, as you say, we're having I might say open mic, town hall session, workshop, depending how you say it. We've had one here where we took a very short period to say what we're doing, and then just listened. You were there. We listened to what everyone had to say.
I asked a lot of questions.
You did. A lot of good questions. We took notes. We take minutes of it. We're going to produce a summary of that people can read, and we some of it actually we discussed at the classification committee that we held following. We're going to be doing that hopefully in both the US and Europe next year. We're hoping to go to the American Headache Society and listen to what society has. We'd like to go to the European Headache Federation, listen to what they have. We want to come to every one of the International Headache Society meetings from now until we finish the classification work. So again, we can feedback and get more information. And you were there, and there's an interesting range of things that people want us to think about. And we really invite you, if you've got something that's burning, that's itching your ear in the classification, even if it's just a small error, send us an email and tell us. Send me an email and tell me, and we'll make sure it gets fixed up. And if you want something changed, write us a page or so. Say what it is that you want. Give us some references, and I guarantee we'll look at it.
So then there's two approaches. One is actually doing the research, collecting the data, and we talked about that might even be a case series.
Yes.
And the other is doing a deep dive in the literature.
Yes. And we'd encourage people to do. So the more research you can do in classification, the better we're going to be and the stronger the next version will be.
What about more pragmatic questions or ideas? Like, for example, migraine. I know if you've mentioned things like high frequency migraine, and where do we even put that demarcation? So do you want to talk about making it more useful to and more in line with some of the terminology that we already use?
Yes. We talked about that. It's the problem, isn't it? It's this 15-day chronic migraine rule, which most people think is probably not the best rule we ever invented. I can tell you that we heard in the workshop about it. The classification committee spent about an hour talking it through that evening. What we're doing is trying to get all the ideas out and then have a working party, sit with the ideas and tell us what a reasonable way forward is. What I don't want to do is suddenly jump from 15 to 8.
Right.
And then realize that's not a great idea either. It's got such implications for patient care that something like that, I'd rather take a little bit longer and be very careful and get a very considered outcome, you might say. I mean, there are people that want to abolish the term chronic migraine and people who want to stay with it, and everyone in between. So it's difficult. What I learned when I was on the previous classification committee, and I certainly respect Gus Olison for all the things he did around this, is how difficult classification is. Because classification is what all you folks do at home. I mean, you do it in your practices and you think about it all the time. And primary headache
obsess about it.
Well, may not obsess, but I get a lot of letters that are a bit obsessive. So I think that it's difficult, and I want to respect that difficulty, respect people's clinical opinions, and do something that's sensible and useful without throwing the baby out with the bathwater.
Yeah, and I think it's also important to mention medication overuse headache, because we talked about that terminology, and maybe in some parts of the world, the idea that overuse is maybe kind of stigmatizing to patients, and it's driven by sometimes prescriptions by doctors and just the mere frequency of migraine. And then you put someone on a CGRP monoclonal antibody or other types of drugs like topiramate, and all of it goes away. So what are your thoughts about that terminology, just so that we hear that?
Well, we're thinking it. I certainly understand that in some jurisdictions the terminology is considered stigmatizing. I'd say also one of the advantages of having a broad geography on the committee and taking broad advice, that's not true everywhere. Some people just shrug their shoulders and it doesn't bother them in some jurisdictions. So what we have to be careful that because the International Classification of Headache Disorders, the first word is what it says on the jar, international. We need to, what we do needs to be comfortable for as much of the world as possible. So I recognize the terminology is an issue. The terminology that says that medication overuse is necessarily causing headache, medication overuse headache, that is quite problematic for the reasons you've set out. And the committee's aware of that. And we're thinking about how to mark the fact that some of our patients are taking too much acute therapy, not because they're bad people, but actually taking too much. Taking opioid on a regular basis is just medically bad for you. Taking a non-steroidal on a regular basis, it could potentially GI side effects and so forth. That's just medically bad for you. It's not a judgment. And I don't want to lose track of the fact that that use or even a triptan on a daily basis, that can be a problem. I don't want to lose track of the fact there's good medicine in saying to someone who's taking regular opioids, regular non-steroids, regular triptans, it's good medicine to actually pare that back. But you've got to do it in a way that doesn't place necessarily any judgment because, you know, it's just good medicine. It's good medicine to ask people to lose weight. It's good medicine to make sure blood pressure's normal. You know, we need to find ways of making sure that good medicine is not stigmatizing, it just benefits patients.
Yeah. And then we also talked about the notes that maybe people are not spending enough time reading, and
That's right.
I have read those. But is there a way to make them a little bit more in the forefront? Use different font or highlight, I don't know, something that makes it more usable.
Yeah, one thing I'm thinking about is how some of that might be better presented graphically.
Yeah.
I'm not sure in 2025, 2026, 2027 that long paragraphs of text
condensed with small font
is actually the best way to communicate with people. I think we've seen quite a move clearly in the online world, even with journals, with graphical abstracts, that we're all getting used to that form of communication, and certainly as generations move on, that's a more popular thing. So I think we have to sort of get with the program, so to speak, and we may be better off thinking, or we are better off, and we are thinking about how to transform some of that text, not lose it. If people want to read, that's great. I encourage reading. But for communication purposes, I think something more graphical may be a much better way to grab people that there are other details other than the strict criteria.
I know our artists are going to be very happy about that.
Yes, good.
And so, you know,
if anyone's got any ideas, any sort of, take a look at some of the notes. If you have an idea for something graphical that may be able to convey that to our colleagues, do not hesitate to send it to us. If we use it, well, of course, we'll acknowledge the people who send them along. But really, I'm no artist. I mean, I can barely draw a straight line. So if people have got ideas, just send them along.
And obviously, I also have this membership role. And so I want to hear from you what being a part of this society has done for you personally, your career. I know you have all these friends. And but tell me.
Being part of the International Headache Society, it provides you with a home, a way of evolving your career or clinical practice with like-minded people. Come to the meetings, you read the journal, the website. You're talking to people who think the same. Not every neurologist, and you know this, not every neurologist thinks headache is really cool and really interesting, but everyone in the International Headache Society does. So if you think that headache is cool, important, a disorder where we can really do good, then International Headache Society, I find that that's a home. You come and join us.
Great. Well, so this is unscripted conversation.
Yes.
Thank you for being here, and thank you so much, and good luck on the journey.
Thank you very much. Thanks. Thanks, everyone.